E-College of On behalf of E-College of Critical Care, I like to invite you all to this meeting. Today we are going to discuss about the role of prothrombin concentrate complex in perioperative bleeding and other aspects of usage of prothrombin concentrate complex. We have Dr. Raghunath Aldakatti. Dr. Raghunath Aldakatti is a renowned intensivist, a very hardworking and knowledgeable intensivist, and he works at Mysore, and he's an integral part of the E-College of Critical Care Medicine. Over to you, Dr. Raghunath.
Thank you, sir. Allow me to share this screen.
Yeah.
Okay. Thank you, Dr. Yash, for kind introduction. Next, around 25 to 30 minutes, I'm going to discuss on use of factor concentrate in the operating room, especially when, why, and how much. These are the questions I'm going to ask with respect to perioperative bleeding. So, no affiliations or financial involvement with subject matter or material discussed here. So we all know that perioperative bleeding is a very common complications following major surgery. So we have option of surgical measures to minimize bleeding. We'll try to do that first as much as possible. But patient may acquire, hemostatic defects, maybe due to hemorrhagic loss, consumption or dilution of coagulation factors and platelets, hypothermia, acidosis, acquired platelet dysfunction, activation of fibrinolytic and inflammatory pathways, anticoagulant use, and platelet inhibitor use. So basically, even though we have option of surgical measure to minimize bleeding or reduce bleeding, these causes will aggravate the bleeding, or if you do not correct these underlying problems, especially hypothermia, acidosis in trauma, whatever you do to treat bleeding, it will not be helpful. So basically, we have to concentrate all these factors before considering even blood and blood products, and as well as these factor concentrates. So try to correct these underlying pathologies, especially hypothermia, acidosis, and correct the anticoagulant use, platelet inhibitor use, those aspects. Then we can think of treatment point of view. So whenever there is a perioperative bleeding is there, most of the time what we use allogenic blood product transfusion, like a packed cell volume, FFB, platelet. So these are the blood and blood products we use. But what we are going to discuss here is rather along with the blood and blood production or after blood and blood product administration, what if factor concentrates available, can I use those factor concentrate in case of perioperative bleeding? So first one, we discuss about fibrinogen, a most important factor, critical factor I can say with respect to hemostasis. Prothrombin complex concentrate is now widely available all over India. Even we are using now prothrombin complex concentrate, recombinant activated factor 7A, and factor 13 concentrate. This is not available at present in India, but first three are available. Whether we can use these products or not, we'll see one by one. So before discussion on factor concentrate, we should know about this hemostasis. We all know that there is a intrinsic pathway which constitute factor 10, factor 9, and factor 8, and extrinsic pathway, tissue factor, factor 7A, and factor 10, which forms the prothrombinase complex, which convert prothrombin to thrombin. This is a very important. This thrombin then cleaves fibrinogen into fibrin. This fibrin goes into the polymerization, which is facilitated by activated factor 13. Okay, that's how the fibrin cross linkage forms and clot forms. Actually, the clot stabilization happens. So basically, we are discussing on this fibrinogen, which is the most important factor for hemostasis. Which fibrinogen will be converted into fibrin. Fibrin forms the polymerization with the help of factor 13. So we are discussing on fibrinogen and also factor 7A, which is an important factor in case of extrinsic pathway. And we are discussing on factor 13, which helpful in the fibrinogen fibrin polymerization. And the one prothrombin complex concentrate constituted 4-factor. There is a 3-factor PCC is there and 4-factor PCC is also there. So we're coming to this point, whether the factor concentrate levels are associated with excessive bleeding. Means we, before giving any concentrate, we have to ask these 3 questions. One, whether concentrate what I'm giving, factor concentrate I'm giving, whether it's associated with excessive bleeding or not. I have to prove it. If it is associated with excessive bleeding only, then I can give these factor concentrate. Second point, if whether the pre-operative or supplementation can reduce post-operative blood loss, I need some evidence whether by giving these factor concentrate, there is reduction in the blood loss. Third one is there should not be major complications. What is the major complication? Basically, other part of bleeding, that is thrombosis. If you know these factors, then I can consider factor concentrate whether to consider or not in the case of bleeding patients. So first one will go with the fibrinogen. Fibrinogen, as I told, is a very critical factor for hemostasis in the context of perioperative bleeding. We know, depending upon the country availability, we are using cryoprecipitate and fibrinogen concentrate. We are having cryoprecipitate using earlier. Now we are also, there is fibrinogen also available now. We are using it more and more. So this is the first concentrate which critically goes very low during hemorrhage. And as I mentioned, fibrinogen is converted to insoluble fibrin first by thrombin. Thrombin, then with the help of factor 13 goes for polymerization. This is how it will be the mechanism of action with the fibrinogen. So this is the electron microscopy showing the fibrinogen. These are the fibrin polymerization. This is the RBC, pink one, violet one is platelets. This is the clot stabilization is happening through electron microscopy. We can see like this. So first question I want to ask is whether lower fibrinogen levels are associated with the excessive bleeding. So this is an important question, as I mentioned, whether there is a association is there or not. So a lot of studies have proven this. There is a systemic review and meta-analysis, the effects of pre and post-operative fibrinogen levels on blood loss after cardiac surgery. So this is a total 20 studies are involved here. When their association they found that if the pre-operative fibrinogen level is low, there is a definitely post-operative blood loss. Means there is association, strong association between lower fibrinogen level and high bleeding risk. What about post-operative fibrinogen? Yes, even if there is a post-operative fibrinogen level is less, that is associated with the post-operative blood loss. Means lower fibrinogen level associated with the blood loss. That is a very important point and is a very proven already with so many RCTs and meta-analysis. So next question here is whether pre-op supplementation with fibrinogen can reduce post-op blood loss. That is the important question. This is the pre-operative supplementation with the fibrinogen concentrated cardiac surgeries, a randomized control trial by Jepson in 2016. He considered low risk of CABG patient. He started giving 2 grams of fibrinogen immediately before surgery after induction of anesthesia. This is the commonly he gave for few patients. Okay, with respect to placebo, he tried. He found that surprisingly, pre-op supplementation of 2 gram fibrinogen concentrate did not reduce or significantly influence the post-op bleeding or patient without documented hypofibrinogenemia. Means if there is no documentation of hypofibrinogenemia, if you give 2 gram of fibrinogen, it does not reduces post-op bleeding. That is the important point he mentioned here. So what about next study in a major cardiac surgery, high risk of cardiac surgery, effect of fibrinogen concentrate on intraoperative bleeding? He found this case actually, Bellison. He used IV single dose of fibrinogen, he used 2 gram or 3 gram to achieve post-infusion plasma fibrinogen level of 2.5 gram per liter. Means he started giving fibrinogen to get the value this 2.5 gram per liter. He found that there is no much difference in the blood loss if you give fibrinogen or will not give fibrinogen. So surprisingly, there is no, again, administration of fibrinogen concentrate compared with the placebo resulted no significant difference in the amount of intraoperative blood loss. So what went wrong here is, so, and also there is a risk of, thrombosis in some of the patients, not statistically significant, but it is there. Means here we are missing one important point here is, if there is no hypofibrinogenemia, I mean there is no documentation of hypofibrinogenemia, Just like that, if we give fibrinogen, it is not working out, or it doesn't reduce the pre-op or post-op blood loss. So we want to know the critical hypofibrinogenemia. This is an interesting study by 2023 by Richard. He found that, actually is taken from the trauma patient. He found that if fibrinogen is less than 150 milligram per deciliter, means 1.5 gram per liter, is independent associated with the death, irrespective of age, your severity score or GCS. If value is less than 150, there is a risk of death is there. Means that is the value is telling less than 150 is associated with the increased rate of MODS and also need of blood product transfusion. Means this is a critical value where this patient may require fibrinogen. That is how we can identify patient with the low fibrinogen level. So what about the guidelines mentions? These are new guidelines. I request all of you to go through these guidelines. European Society of Anesthesiology and Intensive Care in respect to management of severe perioperative bleeding. This guideline mentions about the use of not only factor concentrate, also mentions when to transfuse hemoglobin blood, when to transfuse platelet, when to stop aspirin, when to stop clopidogrel, when to restart all newer oral anticoagulants. All those gray areas he discussed very clearly and come up with the good guidelines. We can go through these guidelines. So here with this guidelines mentioned that recommend that treatment with fibrinogen concentrate or cryoprecipitate, both can be used here in this case if bleeding is accompanied by hypofibrinogenemia. So if there is a documented hypofibrinogenemia, value is less than 150 milligram per deciliter or 1.5 gram per liter, we can use fibrinogen concentrate. If there is a viscoelastic signs like a thromboelastography or rotation thromboelastometry is there, then also we can, if there is a functional fibrinogen deficit is there, then also we can use fibrinogen transfusion. Fibrinogen substitution in women with ongoing postpartum hemorrhage and fibrinogen level about 200 milligram per deciliter means in case of PPH patient, this value should be higher side. It should be 200 milligram per deciliter to transfer. Trigger should be little bit higher value, 200 milligram per deciliter. FIFTEM or FIFTEM. FIFTEM means it is again thromboelastography. FIFTEM showing A5 greater than 12 millimeter means it should be less than 200. We have to transfuse fibrinogen. That's what in PPH dimensions. But this is another guidelines by International Society of Thrombosis Hemostasis. It mentions that suggest against fibrinogen concentrate if preemptive administration, means prophylactic administration of fibrinogen is not indicated in any of the patients. If there's a documentation, we can use it. That is the one. And again, it mentions the same value. Actually, 150 is the target point. Then less than we can transfuse. More than that, we don't need to transfuse. What is the dose? Dose is 25 to 50 milligram per kg. That is the dose of fibrinogen we can require. 25 to 50 milligram per kg. So what is the cost? What is the available cost in India? We have several products now. Reliance is there, Intas is there. We can use any of the product. This value, cost is around 23,000 to 33,000 for 2 gram. More costly actually compared to our blood and blood products, but definitely helpful if you've done all options. Still, the patient is bleeding. If fibrinogen level, you can use this. So this is the new study, fibrous randomized clinical trial, effect of fibrinogen constant versus cryoprecipitate on blood component transfusion. What is the efficacy with respect to cryoprecipitate? This is an interesting study actually. This study mentions that if in this randomized trial, who underwent cardiac surgery, developed clinical significant bleeding, fibrinogen concentration was found to be non-inferior to cryoprecipitate. Means equal almost. You can use fibrinogen with instead of cryoprecipitate with regard to the number of blood component transfused in 24-hour period of post bypass. You can see here fibrinogen concentration 4 gram has been used here over 10 minutes for 24 hours. Cryoprecipitate used 10 units of cryoprecipitate for 24 hours. They found that there is no much difference, or even it is non-inferior to cryoprecipitate. So this is a mentioning about the efficacy of fibrinogen with respect to cryoprecipitate. What about the cost? Cost effectiveness of fibrinogen with respect to cryoprecipitate. Another new study 2023 mentions that fibrinogen concentrate is cost effective when compared to cryoprecipitate in most of the bleeding adult patients who underwent cardiac surgery with acquired hypofibrinogenemia requiring fibrinogen replacement. Means what I'm telling here is, if you use the dose, if you see a dose of cryoprecipitate comes around 10 units, almost equivalent to the cost of the 4 gram of fibrinogen. That is the cost effectiveness. But India, I feel still more it is a more costlier compared to fibrinogen. But if the patient, if you can have strong evidence of low fibrinogen, consider using fibrinogen when it is available, when cost is not the factor. Coming to the prothrombin complex concentrate is another, factor concentrate is a purified factors that include procoagulant factor like a factor 2, factor 7, factor 9, factor 10. And anticoagulant proteins also consist of, protein C, protein S in variable concentrations. So this non-activated prothrombin complex concentrate is lyophilized human plasma derived vitamin K dependent covalent factor concentrate. According to the factors available, we can consider like a 3-factor PCC, which constitutes factor 2, factor 9, factor 10, and 4-factor PCC also in one, factor 7. So we can use either 3-factor or 4-factor PCC, but 4-factor PCC always better than 3-factor PCC. Basically, it is developed for vitamin K antagonist reversal. That is the basic idea, is to reverse this vitamin K antagonist like acetrom, warfarin reversal. They have to use PCC. That is how it is developed actually. So advantage with respect to FFP. We all know that we are using FFP widely, fresh frozen plasma. What is the difference between FFP if you consider PPP, PCC? PCC has a lot of advantage with respect to FFP. It is immediately available. So PCC comes in like a vials. We can use very short duration. So there is no need of ABO compatibility or thawing process and all. And it can be administered rapidly. No need to take more time. And there is no worry about overload, like a circulatory overload. We call it as TACO, transfusion circulatory overload, or TRALI, transfer related acute leg injury. There is no worry at all. So there is a lot of advantage with respect to prothrombin complex concentrate with compared to FFB. So we can use more and more PCC when there is option of FFP and PCC is available, especially with respect to antagonist, like a vitamin K antagonist reversal is required. So what about in the other surgeries, like in perioperative bleeding? Comparison of 4-factor of PCC and with the fresh frozen plasma for management of hemorrhage during after cardiac surgery in 2021 study it is. In this study, they used 1,500 international units less than 60 kg, 2,000 international units for patient more than 60 kg, and compared with the FFP, 3 units for weighing less than 60 kg, 4 units for the more than 60 kg. When they compared, they found that PCS group had significantly lower blood loss and received fewer allogenic blood transfusion, whereas number of thromboembolic events was similar. So this is a very interesting study. It found that it is a more efficacious compared to FFP and having fewer blood transfusion problems and thromboembolic events also. So another trial, Prophecies trial, when they compared with the PCC versus FFP in adult undergoing heart surgery, pilot randomized control trial, this used the dose of 15 international units per kg based on factor 9. Always the calculation with the kg per kg goes with the factor 9 with respect to factor 9. FFP, they use 15 ml per kg. If bleeding continued after first transfusion of PCC or FFP, standard care was administered. In this case also, they found that transfusion requirement was similar in two groups, both PCC and FFP, and there is no increase in thromboembolic events. So when there is no thromboembolic risk is there, and both are equal, and there is a lot of advantage with the PCC when compared to FFP. Why can't use prothrombin complex concentrate not only with the vitamin antagonist reversal in other patient like a perioperative bleeding also? That is a question. But recent study like a PROACT randomized clinical trial, it is a French trauma center with respect to trauma at risk of massive transfusion. They used 1 ml per kg of 4-factor PCC or 25 international units factor 9 per kg with respect to 1 ml per kg of saline solution. They found that there is a possibility of risk of thrombosis. This recent evidence mentioning. So even though statistically not significant, the thromboembolic events are more occurred with respect to PCC. Because of this guidelines, what they mention is, yes, 4-factor PCC to reverse vitamin K antagonist effect should be used as a first line. The dose will be 25 international units factor 9 per kg at INR of 4 or transfusion of plasma. With respect to plasma, it is always better. So what about in a bleeding patient with vitamin K antagonist coagulopathy? In that case, dose should be goes higher dose. It not only 25, you can goes up to 50 international unit per kg. plus vitamin K of 5 to 10 milligram per kg can be used if there is a bleeding is there. For reversal, you can use 25 international units per kg. What about in case of newer oral anticoagulant like rivaroxaban, apixaban, and edoxaban, which are anti-XA agents, as it consent of factor 10, it can suggest use of PCC 25 international units per kg at first rather than andaxinate alpha in bleeding patient with the anti-XA agents. So here you can, even for oral anticoagulants also, we can use this medicine. That is very interesting actually. I recommend treatment with the PCC if available instead of FIP. Bleeding is accompanied by signs of coagulation factor deficiency, like a viscoelastic signs of functional coagulation factor deficiency or high PT ratio. Even in case of if the bleeding is there with respect to FIP, you can use PCC. That is a newer evidence mentioning. So there is a concern of small risk of thromboembolic events is there, but we need a more randomized controlled studies on that. So cost, if you see here, it cost is again it comes with the lyophilase concentrate, 250 units, 500 units, 1000 units, but actual dose is required around 1500, 2000 units. So cost will goes up to 80,000 to 1,60,000. Can be that is a very costly compared to FFP, but this is an option when the reject cost is not the concern. So what about factor 7A? This is the another factor concentrate which is widely used for hemophilia A and B with inhibitors, congenital factor 7 deficiency, Glanzmann's thrombocythemia, perioperative management adults with the acquired hemophilia. This is a very classical indication, FDA approval indication for factor 7A. Standard dose is 90 to 120 micron per kg given in 2 to 3 hours till effective hemostasis is achieved. That is the dose every 2 to 3 hours you have to repeat till the hemostasis achieved. That is the recombinant factor 7A dose. But if you see, there is a 140-fold increase in use of this factor 7A, and 97% of this use is off-label. Off-label means it is not FDA approval. Like a traumatic bleeding, yes, we are using. Perioperative bleeding, yes, we are using. Postpartum hemorrhage, at its work. ICH, there is a evidence, but recent studies have shown that there is a risk of ischemia, bleeding of in liver disease, anticoagulant associated bleeding. These are all our off-label use, not guidelines or nothing is giving straight away to mention to use this factor 7A when all options are finished. If you don't have any other option, then we can consider factor 7A. So we'll see what is in case of perioperative bleeding. In case of undergoing cardiac surgery with severe bleeding, here in the safety and efficacy of refined activate factor 7A in the settings of cardiac surgery. So they compared with the 40 microgram per kg and 80 microgram per kg. This is a effect will be dose dependent, that you should know, and also risk is also dose dependent. If you use 40 versus 80, they found that the risk of patient requiring reoperation and also bleeding blood transfer requirement was less if you use compared to placebo 40 and compared to 40 80 microgram, it is less. So that we should know it is more efficacious. And there is a multiple randomized control trial, 7 RCTs and meta-analysis have shown that it associated with the reduced risk of receiving allogenic back-ordered blood transfusion. Means the need of blood transfusion will be less if you use factor 7A in case of major surgical procedures. This is the efficacy safety of factor 7A. And you should know that dose is 50 micron per kg. Factor 7A works better, significant effect compared to lesser than dose. In subgroup analysis, that is what is mentioned. No difference in complication mortality. This is the study mentioning about the even about the risk also. But for the usage of factor 7A, there is a very interesting study by Payne mentioning about the reduced mortality by meeting guideline criteria before using recombinant activate factor 7A in severe trauma patient with massive bleeding. Is a 26 French trauma centers, 112 subject to use. They found that to use factor 7A, we should have hemoglobin more than 8, serum fibrinogen more than 1 gram per liter, platelet should be more than 50, pH should be more than 7.20, body temperature more than 34. Then only this factor 7 works better. There is a mortality benefit is there along with the requirement of blood products transfusion be less. This is the means, as I mentioned earlier in first slide only, this is a requirement for the any factor concentrate, especially factor 7 it is proven now. So make sure that these values are met before giving factor 7A. What are the guidelines mentioned here? Suggested the use only if all other options to control hemostasis have failed, with special caution with respect to arterial thrombosis. This is the recent guidelines by European Society of Anesthesiology and Intensive Care. So use only factor 7A when all other options have left. And make sure that before giving factor 7A, make sure fibrinogen is more than 1.5, platelet count is, more than 50, pH is more than 7.2, and body temperature more than 34. And it should not be used, as a first line therapy, especially in off-label use. Off-label use, make sure you do give all the best possible options. Later, you can consider as a last option. And one interesting is, if there is a ponderperinox related severe bleeding is there, we can use factor 7A. That is suggested use. Off-label treatment is also available now. So cost comes in 1 gram, 2 gram, 6 gram, and I think it is 10 gram or 12 gram. Nova 7, it is 1 gram cost about 70,000, very costly. Now it is not. Earlier it is available. Last 1 month, I tried for one patient, I didn't get this. So the availability is again is a factor now in our India. So factor 13 is another few points actually. We all know that factor 13 is also an important factor for the polymerization of fibrinogen to fibrin polymerization. But somehow in some patient, in spite of all the measures, there will be continued bleeding, especially in case of orthopedic surgery, even in cardiac surgery. There they found that factor 13 deficiency, that is called acquired factor 13 deficiency, when it is defined as factor 13 plasma content less than 60% normal. So we have plasma-derived factor 13 concentrate and recombinant factor 13 indicated for the patient with the congenital factor 13 deficiency, which is a rare, very rare autosomal recessive bleeding diathesis. But acquired is we are seeing now because we have option of measuring. So we are identifying factor 13 deficiency, whether it is really associated bleeding or not. That is again, we need a lot of evidence for that. This is a multi-center clinical trial, RCT trial, placebo control, to know the efficacy and safety of factor 13. So in surgical patient, they use the dose of 17.5 intra-units per kg and 35 international per kg, and placebo. They found that yes, there is a replenishment of factor 13 levels, may be associated with bleeding, but replenishment of factor 13 levels has no effect on the transfusion avoidance, transfusion requirement, reoperation. Means it is not yet proven. So we cannot use just like that factor 13. So many studies are coming up with the efficacy of factor 13. At present guidelines, both recent and even this hematology guidelines mention against the factor 13. So suggest in presence of ongoing bleeding, unresponsive to multimodal coagulation therapy, wound healing defects in critical ill to monitor factor 13 and correct deficiency. Means when there is a unresponsive to multimodal coagulation, then check factor 13. If that is deficient, we can transfuse this. That is option. So this comes around Nova 13. So 2,000 to 3,125 international units. So cost is, I don't know, we are not used. So whenever we want to use, no, we can use this. The best thing actually, we can use either thromboelastography or rotem. We can use XTEM or FIPTEM. So with that, we can transfuse blood and blood transfusion. Here, if you can see here, when lab-based decisions are available, if fibrinogen 200 milligram per deciliter, or your XTEM showing less than 45 millimeter in thromboelastography, or FIPTEM is less than 30 millimeter is there, 13 millimeter, then we can go for 2 gram of fibrinogen, or you can go for precipitate 5 units. If it is less than 150 and XTEM is less than 45 millimeter and FIPTEM is less than 10, we can go for 4 gram of fibrinogen. That is how we can give medicine with respect to TEZ or ROTEM. If PTINR is more than 1.5 times the normal, or CT XTEM is more than 80 seconds, we can go for FFP, or we can consider PCC also 10 to 20 international units per kg, or you can go for factor 7A 1 to 2 milligram. So here you can refractory bleed, you can consider PCC or factor 7A. PCC can be used instead of FFP, cost is not the factor. So in case of cardiac surgery, this is the non-cardiac surgery. In case of cardiac surgery, again go for, you can go for a FIPTEM fibrinogen less than 200, or FIPTEM is less than 13, use 5 units cryo or 1 gram of fibrinogen. If FIPTEM is less than 10, you can go for 10 units cryo or 2 gram of fibrinogen. So again, INR is more than 1.3 or CT XTEM is more than 80 seconds, you can use either FFP or PCC. If nothing is working out, then we can go for factor 7A. So studies mention recommend the use of standardized hemostatic algorithm with predefined intervention triggers over clinician discretion for the management of coagulopathy. in cardiac surgeries. So this is a conclusion. Use fibrinogen concentrate if bleeding is accompanied by documented hypofibrinogenemia, viscoelastic signs of functional fibrinogen deficit, or plasma level less than 150. Use factor 7A only, all other options have failed, with special precaution with respect to thrombosis. 4-factor PCC may be suitable alternative FFB. Point of care testing of hemostatic function allows specific targeted therapy of coagulopathy. This is what I want to conclude with this topic. Thank you. If any questions is there, I'm very happy to take. So some questions are here. Hello, sir. If you have any question, please go ahead. Okay. No questions are there in this, right? Hello.
No, sir. Hello.
Any questions with respect to? Hello.
Hello.
Yeah. So have any questions with respect to candidates? I think I may very clearly I told about the when to use fibrinogen. I know it is difficult to get it, but when the option is there, you can use it, not only blood and blood product transfusion. But one thing I want to mention here is, read that article, as I mentioned, the European Society of Anesthesiology and Intensive Care, where they mentions even, when to use blood and blood products, when to stop ecosprin, when to stop clopidogrel, when to stop newer oral anticoagulants, when to restart, those options actually. I think Dr. Yash is there.
Yeah. Thank you, Dr. Raghunath. Wonderful talk.
Yes,
And you gave good insight into it. We have been using it for some years now. Initially, we used to import the molecule, and now some companies, Intas and others, are available. See, results are always good. If you can correct the root cause, then the drug is always going to work. Bleeding will be stopped, that is for sure. But if it is a surgical bleed, you have to tackle that. If it is a capillary bleed, medical bleed, what we call, then you can go along with the molecule and have the effect. But if it is surgical, then surgical correction has to be done.
yes.
Otherwise, it's like a miracle molecule.
Yes.
It will always have effect. But before giving, just to be sure, optimize the patient in terms of reverse acidosis. If there is hypocalcemia, try to correct that, and temperature control, acidosis control.
So have you used fibrinogen and PCC, sir?
PCC I have used many a times. Fibrinogen alone, I haven't used. PCC I have used many a times. We have been using for almost 15, 16 years now.
Yes, yes.
Yeah,
PCC
COVID also we could use for quite a number of patients.
Yes.
PCC results are fantastic.
Any complication you experience with respect to thrombosis?
The risk is high, but if we see most of the time we are giving for the life-threatening bleed. So there is a remote risk. One in say I think 16 patients they say it can have some thrombotic complication, but we haven't seen any major complication. We must have used about 15, 16 patients so far.
Yes. Whenever there actually and there is a risk of fluid overload and the risk of trial, then we can easily you can use PCC and get rid of all these
And second
complications.
problem is many of the places the availability of blood products takes a lot of time.
Yes.
That is a bigger challenge.
Yes. To get a blood itself, blood itself is a bigger challenge. Yes. There we can use PCC also, and just a while, just give it off like any other drug you are giving. Very easy to give.
And now newer oral anticoagulant is another major challenge.
Yes.
This is one of the antidote for newer oral anticoagulants.
Yes, PCC now they are suggesting for the newer oral anticoagulants, except dabigatran, like rivaroxaban, apixaban, they are using. Whichever the anti-XA agents are there, they can we can use the PCC for bleeding with respect to newer oral anticoagulants. So recently we use, sir, we have very good result. Even I use fibrinogen. That's what we cannot use just like that. Only there is some documentation should be there. Otherwise, again, there is associated risk of we don't know when what we are tackling. Just we give one drug out. Definitely there is a risk of complications will be there.
Okay.
So I don't think any major questions are in this, I think.
No, no, no. Okay. If there are no further questions, then probably we can end the session. Thank you, Dr. Raghunath, and thank you,
Okay.
Raymed and E College of Critical Care Medicine.
Thank you.
Thank you, Shravya. Thank you, all the audience. Thank you so much for giving this opportunity. Thank you.